open this, adjust this chamber up and down to the level that it's ordered, tighten it, and then number 5, go back and make sure every single stopcock is open. So it can, when you want to test if this is working or not, here's what you do. You take this off the pole and you drop it, bring it down. So this level, you drop it, bring it lower than the head of the patient, so the pressure over there will be higher than this, and it's going to pour, and you'll see it's dripping. That means it's working. That means you're testing that there's not a debris clogging this thing, because that can possibly. If you have 1 or 2 hours goes by and you're not draining anything, you got to be calling me. Is this blocked? Is this clogged or not? Then I will tell you. Take it off, bring it down, make sure it drips or not, you know. Sometimes the brain is so swollen that shuts down the ventricles. So, you know, there's no CSF. That's bad trauma situations, you know. But what I don't want you guys to do is by no means ever flush, you know, like saline stuff, because it can go towards the brain and can cause infection. If you want to do that, you know, I need to be there showing you guys how to do it. And the way you do it is you block, for example, one side, wipe out with alcohol, betadine, and all that, and just maybe 1 or 2 cc's only of sterile saline. You put it in and flush to just goes inside the head, the ventricle, to sort of if there's a clog inside. But I would rather be there and showing you guys. If it's a middle of the night emergency, I can tell you through like the iPad, you know. So that's one way. And then you can block this towards this side, and then you flush, it goes towards that side, the fluid, you know, to wash it out this way. And then you empty it here in the collection bag, you close it again, and then you make sure everything is open, and then you can test it, make sure it drips, and then you put it according to the, okay? So this is just basically showing the same thing, not how I'm showing. This is the ruler. You're putting the 0 of this at the ear level of the patient in the horizontal. So this just shows us that. Here's the dressing, comes out. Make sure all of these. This is stopcock. This is stopcock. This is stopcock. This one. All of that is open. And this is the knob that you open and close in order to raise the chamber, you know, up and down. And this is just a collection bag. Every hour it collects in the chamber. Once you measure it, note it, document it, then you open that, empty it in the bag, close it again, so it measures for the next hour. Same thing, you know, that's just the overall view of the system, okay? Inside the head, tunneled out, dressing, all these stopcocks that needs to be open. This is the 0 level to the horizontal. 0 is right there. And then we have put this chamber, collecting chamber, at certain centimeters, 5, 10, 20 centimeters above the 0, and making sure everything is open. So anytime the pressure is above, if you put it here, if you have placed it at 15, you're telling the system that anytime the pressure inside the head goes above 15, start draining. So if it's 17 or 19 or 21, it will be draining, but if it's 13 or 10 or 6, it won't be draining. But it has to be open so it allows. Now, this is the simpler one, which you see. We have had a few ventriculostomies here. Now, this is the simpler subdural drain that we talked about. Here's the subdural space, blood clot inside the dura, underneath the dura, underneath the bone, but outside the surface of the brain. So that's why it accumulates and then compresses the brain. And this is a subdural drain. It's sitting there. It's connected to usually a red Robinson catheter and a bile bag. Has no measures, no nothing, you know. And this bag and this catheter is just laying on the pillow next to the patient, you know. Wherever the patient's head is, that is there. So you don't have to mess with any of those things as with the ventriculostomy. But this is a closed system. So a lot of them have stopcock and all that. So please don't empty, because it can air and bacteria can go inside and cause a subdural abscess or empyema. Only measure it, okay? Unless it gets to a point, and after, usually these are taken out in 24 or 48 hours, you know? It's rare for that period of time for this whole thing to be so full that there's no room. In that case, I will be there, you know, and we can empty this and close it in a controlled fashion, you know? And the way you do it, you clamp this so no air or nothing gets towards the brain, empty it, close it back, open the clamp, you know? But don't do it unless I specifically say. Okay, so here's the case report for, this is a real case from our ICU. Okay. Patient comes in, 68-year-old guy with end-stage renal disease on dialysis, okay? And CT scan is done. That CT scan is supposedly, I'll show you here. Okay, so this is the CT again. The white is the calcium in the bone in the skull, so that shows basically the skull. The gray is the substance of the brain. This is right half, left half. These are the ventricles, the catheter, the cavities with CSF inside it, okay? So here is the surface of the brain, the cortex, attached to the inner skull, okay? Look at what's happening here. Look from there to there, there to there, there to there. Something else is there, which you don't have it on this side. So this was a subdural hematoma, but not of the usual type, which is venous, from a little bridging vein pop causing bleeding. This is, if you see here, you see a little dark area and then whitish area, dark area, whitish area. This is equivalent to hyperacute. This whitish stuff is acute blood, but this dark in a bubbly popcorn fashion intermixed with dark and white signals is hyperacute. That means as this patient is on the scan, they're getting this scan, they're hemorrhaging right now. This is acute blood, you know, pumping, and I will show you that. So this is an emergency. Even our radiologist, because it's not common, read this as just acute subdural hematoma. This was a hyperacute, this is death within minutes. So we took this guy from ER. The minute I was home, I asked the ER doctor to send me the image. That's why. I have to see all these images. Can't go by a report of somebody else. And as soon as I saw, oh my God, this is a hyperacute subdural. I called the OR, Conrad, you guys know who I'm talking about. So I called Conrad, he said, yeah, we are available, they just finished the case. And I told him, I think I talked to you also, and I said, here's what's going on. Please go get this patient. And I jumped in the car and drove like 90 miles an hour from where I was coming, you know, which is not good, but I was really trying to get to this. Anyway, by the time I get there within 15 minutes, you know, Conrad and the OR team and Diane, everybody has done a fabulous job. Moved this patient. The patient was intubated on the operating room table. I even told Conrad to start shaving the left side of the head. This is the left side. So this view is like, imagine, cut the head like this, and then look from feet up, you know? So this is my left hand, my right hand. So we're looking from the feet of the patient up. This is his left side, and that's his right side. So I don't shave the left side. So I get there, immediately prep, boom, 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 open. And within 7 minutes from the time that I come there until we open the skin, open the bone, open the dura, get to the decompress the brain, took 7 minutes, which is a national record, you know, seriously. And I will show you the video of this. And we found it was an artery pumping. There was big blood clot on the surface of the brain. As soon as I took the clot out, you see the artery, pss, pss, pss. So the cortical arterial vessel was injured, which I will show you this. Let me first show you this. all the head is open. This is the scalp. This is the muscle. Bone is taken out. This is all the blood clot. You see, he's irrigating. I'm taking the blood clot. This is now you see the surface of the brain. Okay, so this is the surface of the brain. These are the vessels, and look. You see this here?
Wow.
Pumping. This is it. The blood fills up so fast that I'm trying to show, but look right there, it's pumping blood right there. And this is a coagulator, bipolar. So I'm asking, there are 5 people, like 5 or 6 people are standing here watching me. So I'm asking one of them to step on the bipolar pedal because I'm just trying to locate the bleeding vessel. So everybody's trying to just offer to other one. I said, please, anyone, just coagulate it. So they finally coagulated it, you know? And I can show you here again. This is 1 minute. Blood clot is taken out. There's a big blood clot. The dura is open here. You see the surface of the brain right there. And here it's just filling up, pulling up all the blood, but this is right there. And you will see in a minute. Right there. So that's the ruptured artery. Okay? So I'm trying to keep the bleeding under control and locate it, find the bleeder, catch it with this bipolar thing. So I'm asking somebody to step on the pedal. Here. Because as soon as they step on it, then this coagulates and stops the bleeding. That's it. You know? And then, so it took 7 minutes, but you know. Anyway. So let's go over the view of this thing here. Okay. So here's the hyperacute bleeding, and I talked with our own radiologist, sort of educating them what this situation is, which is absolutely amazing, because they haven't seen, it's a rare thing, it's usually venous. Then, right after the surgery, patient recovers well, starts moving, you know, still sleepy, and I kept him intubated because I want him to be sedated for the next 20 to 48 hours to keep a very tight blood pressure control. This is a renal dialysis patient, and hypertension, it tells you that all these vessels in the brain that he has are fragile. You know, they're fragile and can pop. So here, the dark area you see is air, you know? So the bone is open, as you saw. Blood clots is all taken, all the whitish stuff is taken out, which was the acute blood. And then the bone, dura is closed, the bone is placed, and the skin is closed. And this is a beautiful scan. You see this is the ventricles again, you know? All this was the acute blood is gone. The dark area is just air, so it looks good. And this is, I usually get it after surgery, after recovery, go on the way to ICU, I get a scan, CT, to have a baseline like that, and then we go, okay, to ICU. So in the ICU, the orders are placed strictly to keep the blood pressure for this patient less than 150. So if it gets above 150, start the nitrite drip and titrate, you know, to keep it below 150, okay? So, at this point, it's about 1 p.m., 12:31 p.m., okay? Everything is good, and the nurse who was there accepted the patient, fantastic, did a great job, was on top of it until 7 p.m. There's a change of shift, okay? And I usually call a bunch of times to make sure it's okay, and I tell everyone, here's my cell, any question, any problem, just 10 seconds of call, boom, you know? And thank you, Diane, for reminding me. I've also reminded everyone, if you're not sure what you're seeing, you're worried about it, get the IPAN, you know? Let me, put it on me, you know? Don't try to figure it out if you're not comfortable with it. About 7, so change of shift is 7, everything is good, and I put the